Thank you all for being here. At least a few of you have stopped me outside to be like, what are we talking about in that lecture? And the other thing about this topic is I really enjoyed some of the lectures yesterday. Drs. Estrada and oh my God, it's escaping me. But anyway, at the end of the day, Dr. Campanelli, if you were in there, are hilarious. Like, they are just hilarious. And there's nothing I prefer more than a hilarious lecturer. And Dr. Lopez started that off across the street. And as I was sitting there last night, I was like, I got no jokes about antibiotic resistance. So join my doom spiral. And just embrace the fact that it's going to be really hard to find humor in this topic, as much as I really tried. All right. So we have kind of a mixed audience in here. I see quite a few familiar faces, so thank you for coming to see me talk yet again. I appreciate that. But this is really aimed at the operations tract because this is a big picture question, I think, for shelter medicine and for shelters in general. And it's one of those topics that we need to look at as individual organizations, but also as an industry and start thinking about. And I hope by the time I get through this lecture, you'll understand why I think we need to start thinking about it. And so, One Health is kind of the buzzword that we've been kicking around for a decade or more now. And if you say to pretty much anybody on the street, what are these One Health initiatives about? It's like people, animals, environment. Like, sure. If you want to get money for a grant at this point, you've got to figure out how to squeeze One Health into that. And you want to make sure that you've got collaborators across various areas of expertise. And so, I make a joke about that, but veterinary medicine, I think, has been really overlooked in this process. And yet we are somewhat One Health from the get-go with the diversity of the types of work that we do as veterinarians. And so the animal piece is obvious. The people piece, any one of us knows if you work in this field, the people are everything. And then the environmental piece is starting to rise a little bit higher in terms of how we make decisions, products that we use, sustainability for both our facilities and our disposables. How do we think about these big picture problems when we're also really focused on those day-to-day problems and activities that we are tackling? And it can feel like a real balancing act because it is in thinking about our decisions. And so whenever I see the phrase One Health tossed out, I'm being a bit cynical, but I'm like, okay, yes, you need to get that in there for that grant, but what are you really doing that's One Health? And so the CDC, and a lot of this stuff I have pulled from various agencies, the CDC has tried to do this sort of PR marketing campaign to the public to say, what does this really involve in terms of how you think about what you do in your life and what you do in your professional life? And so zoonotic disease is the one that rises high, right? In animal sheltering and animal welfare, we've long had a role in rabies control, for instance. We are often thinking about zoonotic diseases in our organizations. I want to point out antibiotic resistance is the second bullet on this slide, and that's where we're going to spend some focused time today. Food safety and security, I think, is the one that's got the bigger amount of attention from our federal government, and I'll talk a little bit about that. But that is really also where a lot of our veterinary work is happening, is in food safety and production animals, and where a lot of the early regulations are starting to come down the pike. Vector-borne diseases, if you live in the Northeast, it's all about ticks, right? So that's fairly high on people's list. Environmental health, a little bit fuzzier in terms of what that means, but certainly the aspects of not only what are we doing to our environment and climate change, but also looking at kind of our microenvironments in terms of what we're dumping into the environment or what we're dumping into our water sources, chronic diseases. And then we get into kind of the human-animal bond realm, mental health, the roles that pets play in our emotional health. And all of those things really come to the surface, I think, with sheltering and veterinary medicine. So that tends to be an area in terms of human-animal bond where we've been able to put a good amount of attention, and I think actually more research than what we've done around antibiotic use and antibiotic choices. And so why does it matter? Here's my first doom slide. So annual deaths from antimicrobial resistant bacteria. On a global basis, we are currently looking at about 700,000 human deaths per year due to antibiotic resistant bacteria. There are some projections that we are going to be at about 10 million deaths globally from resistant bacterial organisms by 2050. And if that projection is true, it will actually surpass cancer as a leading cause of death on a global level. So welcome to the doom spiral. And part of it in calling it out is because by addressing it in terms of the urgency, we're more likely to get movement on a large scale. But then I would also argue, I bring it to you today to say, what role do we play on a smaller scale? Like, what are the things we can do to try and counteract this? To touch on what antibiotic resistance means for bacteria, just to make sure we're all on the same page, the way that we measure that is by looking at what concentration of an antibiotic will then impact the growth of bacteria. And so to put it in a lab setting, you literally take the antibiotic, dilute it out at various dilutions, expose it to the agent in question, and then see what level you need in order to counteract it, or if it's entirely resistant and it doesn't inhibit bacterial growth. So this is what is kind of happening on a very basic science level to define what antibiotic resistance is. And so how does this happen? Let me see if I did manage to put that as the next slide. Oh, and then in deciding whether an antibiotic works or not, because at some point you're going to have a dilution where it's not effective against the bacteria. So we decide that break point. So what is the level? So what is the concentration we need in order for it to be effective against that bacterial agent? And then is that a level we can actually use in terms of toxicity and all of those things? And so when people in the labs are looking at these questions, or if you send them a culture and sensitivity, they are running a minimum inhibitory concentration on the organisms that grow on that culture and sensitivity that you sent. And then they'll send you back a report on what antibiotics will be effective against those agents. And then you have to make choices based on not only, okay, this is now sensitive to this agent, you have to make choices based on where is the infection in the body? Does the antibiotic actually get there? Can I actually give this sort of concentration and not cause negative impact? There's all sorts of other aspects that you're thinking about, not to mention the practical aspects, like, can I get that antibiotic? Can I afford that antibiotic? Like, can we administer this antibiotic to the animal? And so all of those pieces come into play, and that's more about the stewardship issues that I'll talk about. So antimicrobial resistance is a One Health problem. The CDC will tell you this. Anybody working on this problem will tell you this. And what I want to point out on this slide, and I want to give credit to Casey Kazar, and I'll talk about her, she's a collaborator on a couple of projects I'm working on, is that if you go to the CDC page, you will actually only get from that human hospital side over, because she created the rest of it, okay? And so we are fairly used to thinking about the fact that if we have resistant bacteria, they often, where we will see most of the reports and the work being done, they are getting into our food systems. So we have contaminated meat, we have contaminated vegetables, the manure is spread on crops, and then we end up with it on our vegetable farms or in our meat products, and then we ingest them, and then we have a human outbreak, right? And then that makes the news, and everybody stops buying romaine lettuce. And if you're not paying attention to the news, you're like, why can't I find any romaine lettuce? Or you're suddenly raging, going through your cabinets, making sure that the peanut butter that you have is not the peanut butter in the report, right? Like, this is what we do now. It's what we do. And then the bigger issue, too, is that people can essentially spread it to people, and where we tend to see this happening now is our healthcare facilities, which is the last place that we want to see these resistant organisms popping up, but is indeed often the first place that they pop up because of the use of antibiotics, both topically and orally, and then essentially having contaminated surfaces, contaminated equipment, contaminated people acting as the passageways for that. And so this is where a lot of the work is, and for good reason. But for those of us thinking about these issues, working in the companion animal sphere, we have to remember that our companion animals are also part of these loops, right? They are getting increasingly antibiotic choices that are potentially higher, kind of on the lists of antibiotics. We are going for more and more expensive treatments. We may be using things that in the past were reserved for humans only, and they certainly have an incredible value as individuals to us. As shelter veterinarians and leaders, we also have to pay attention to what we're doing on a population level. And that's where I will spend a lot of the time today, because as a private practice veterinarian standing in a practice, I am making decisions often in that moment based on that client and that animal, Potentially, if I'm really kind of keyed into the bigger issues, I might be thinking about that, but often it's that urgency, right? When I'm working in a shelter, I'm looking at an entire population of animals and I'm working on a policy or protocol basis. And so my impact actually has potential to be larger because I'm working on a population level. I'll pause here because I love to tell stories, and maybe this can be my funny part. When I went into practice, I went into general practice out of veterinary school. And I graduated in 2003, which was like the big development of fluoroquinolones. Like that was the new thing, and they like killed everything. And like you reach for the fluoroquinolone, and we only really had enterofloxacin at that point. So I went into a practice that was emergency general practice. We had 24-hour care. We took in emergencies until midnight. It was very, very busy, urban sort of setting. And my boss had like seized on enterofloxacin. Like that was the new drug. It fixed everything. Like why would you bother with anything else? And I had this very savvy technician who at one point was like, you know what his memoir is going to be? I was like, titled? I was like, no. He's like, When Baytril Isn't Enough. And I paused and was like, but it was kind of true. So there you go. There's the story. And I always think of that when I do have to reach for a fluoroquinolone, I better have a really good reason because I don't want that to be my memoir title. So anyway, back to the picture. I love the fact that she built the dog into this picture. And Dr. Kazar's primary work is in food animal and production, so I'll pull a couple other studies from her. But she has one arm kind of in companion animal and has done a couple studies around that realm, and honestly, there aren't many. There's not much happening, kind of looking at antibiotic resistance and antibiotic use in companion animals compared to the other fields. So how does this happen? How do we get these superbugs in a way that doesn't sound like science fiction? And so the true definition of a multi-drug resistant bacteria is one that is resistant to 3 or more classes of antibiotics. And this happens because bacteria are super smart and they're really generous. And so they like to share amongst themselves. And so essentially you'll get bacterial agents hanging out together that then transmit genetic material. And then that genetic material gives them the ability to evade antibiotics because they're trying to get by just like everybody else, right? And so that can happen in a couple ways. One is that they can actually inherit the ability to inactivate the antibiotic. They just got a secret force field, and now it no longer works against them. They can inherit essentially a piece of genetic material that gives them an efflux pump. So even if the antibiotic comes around, they just pump it out, and they get rid of it, and they can eliminate it. Or they can inherit a superpower that allows them to actually modify proteins that will impact how the bacteria and the antibiotic react together to make it ineffective. And so they essentially gain genetic power to evade the tools we have to fight them. And this can happen in many circumstances. It's a natural process. It's going to happen. But we can essentially enable this process by continually exposing them to different antibiotics so that they get smarter about it, by essentially creating really large loads of mixed bacterial agents so they have more neighbors and friends to talk to, and by creating all kinds of stressful environments that allow those sort of interactions because we're not preventing infection, we're not decreasing load. And so the work that we do around the environmental piece is just as important as the work we do around the treatment of the individual animal. We create these situations where they're allowed to essentially assume these superpowers. When it comes to humans, we've been really good at creating bad situations. And so I'm sure many of you have heard about kind of the superbugs, right? Like Salmonella is one we see fairly frequently, whether it is romaine lettuce or whether it is peanut butter. 2 out of 10 Salmonella and Campylobacter infections in humans at this point are resistant to clinically important antimicrobials. 2 out of 10. 1 out of 10 is resistant Salmonella are multi-drug resistant. So you've really been limited in your ability to fight those infections. And so these are the agents of concern that we're really watching. Once you kind of get to the multi-drug resistance piece, then the options you have are fairly limited, not only in terms of choices of treatment, but also in terms of hospitalization versus being able to be treated as an outpatient. And then the challenge is that once you're hospitalized, that you're often in an environment where you have a higher chance of being exposed to other agents. And long ongoing treatment with antibiotics for any of these conditions can also set up the pathway for other agents to then select for more drug-resistant agents. And so it becomes this horrible doom spiral of a situation. And so I think it gets a little lighter after this, but if we're looking at this burden of multi-drug resistance, it really goes on the x-axis, we have all of the various antibiotic classes, and on the y-axis, we have the various agents. And then this is actually the global deaths attributable to these agents. And so our worst sort of superbugs at this point, we're looking at Actinobacter, staph and strep species, and E. coli is a big one, along with Klebsiella. And so, but none of these are really things we want to see very often. And we also start to look at kind of the classes of antibiotics that we have, and I will say several of these are not necessarily ones we use regularly in veterinary medicine, but we certainly are using third generation cephalosporins, so that's to the far left. You'll see the fluoroquinolones towards the middle, and the fact that the count in deaths for that in terms of fluoroquinolone resistance is significant. You'll also, as you go across, you see your basic penicillins, your TMP, like some of our more basic antibiotics as well, playing a role in this. And so this is, again, the global burden. And we continue to try to capture this information in the human realm, but we, as I'll show you, have very, very limited information on kind of a widespread scale, certainly not a global scale, in terms of what agents we're seeing in our companion animals, because there's just not the investment in that kind of surveillance at this point. So the CDC's core actions to kind of prevent this antibiotic resistance development is to hit on multiple areas. One is preventing infections and the spread of resistance. And so this is where I say to you, in terms of companion animal populations and what we create in our companion animals, that is where shelter medicine thrives, because we're all about prevention when we're doing things right? Tracking resistance, they have gotten much better at tracking in humans. We really don't have much of that in veterinary medicine at all, like knowing what the scope of the problem is. Improving antibiotic prescribing and stewardship, which I'm going to argue is part of what we need to be thinking about, and we'll talk more about that. And then certainly new drugs and diagnostic tests. I'm trying to make sure that we're identifying agents faster, trying to make sure that we're actually using our cultures and sensitivities when we need them, engaging at that level. But this is the CDC's core actions. And all of this, trying to prevent antibiotic resistance, is part of a much bigger umbrella of antimicrobial stewardship. Making conscious choices about what we're choosing, when we're choosing it, how we're using it. And this is when I'll pause to say, at this point, the slides get super wordy. And I know that's not a principle of preparing a PowerPoint. I know that that's the wrong way to do it. I will say that I left it this way intentionally, partly because you get these as your notes, and the other is because the language matters. So a lot of what I'm going to be talking about now is the actual recommendations, regulations, guidance documents, and so much of that is about what is the language that we're using, and then how do we interpret it in terms of how we actually apply that to our work. And so I tortured you with very wordy slides, but I did it conscientiously or intentionally, so I think that gives me an out. All right, so let's talk about practice principles in antimicrobial stewardship. First, identifying the disease-causing agent and selecting the appropriate drug. Sounds easy. How often do we do that? And how often is it realistic in a shelter, right? Depending on the levels of disease that you have. And so I am by no means saying this is what we have to do every single time, but it is part of the principle, so that if we are seeing common conditions in common situations, then we can start to talk about common treatments. But there will be times when we do need to really identify what is the disease-causing agent happening here. And in shelter medicine, we often think about that as, is it more severe? Are there more cases? Are we seeing an outbreak? That sort of thing. Or do we have a high level of endemic disease, I would argue, that we might want to track down? But one of the first principles is know what you've got and make sure you've got an appropriate drug for it. The second one, attaining effective concentrations of the drug at the site of infection. So can the drug get to where it needs to go? And is it for a sufficient period of time? And this is one where research in human medicine is actually demonstrating that we've probably overestimated what a sufficient period of time is, and that shorter courses of antibiotics can be just as effective and be less likely to result in the development of resistant organisms. And so this sounds like something you just look up in a textbook, but truthfully, this is evolving over time, and we'll talk about some of the specific types of conditions where this work is being done. The other aspect of this is that it means you have to ensure compliance. Pilling cats, pilling dogs in a shelter. So are we able to actually follow the treatment plan and ensure compliance in the prescribing information? And that can be a challenge for owners, but I would argue it's even a broader challenge in a shelter. Choose a dose rate, frequency, and method of administering the dose that maximizes the likelihood of cure, prevents relapse, and minimizes the risk of developing resistance while causing no harm to the animal. Oh, easy. All over it, right? Super easy. And then using specific and supportive treatment to improve the animal's ability to overcome the infection and associated disease conditions, which is about supporting that animal in all kinds of other ways that have maybe nothing to do with the actual thing you're popping into their mouth or putting on their skin. So making sure that you are supporting all of the recovery mechanisms that they need. This is CDC language. This is not my shelter language. There is a balance between individual and population health as well as a One Health issue. So the CDC even recognizes that we're looking at, yes, you have that critical moment with that individual who needs particular treatment, but you also are really thinking about how does this impact the broader population and the environment in potentially negative ways. And then the last bullet I'm going to end with today and come back to, cost and access are important for compliance. So I probably don't need to tell you that health inequity in the US is a challenge, and access to various treatments is often limited by your insurance and your doctor, potentially by your geography. And so there is an aspect of the fact that no matter what we may outline as the best approach in many of these instances, or the most common approach, cost and access absolutely play a role, and that is true in veterinary medicine as well. And I don't think I need to convince anybody about that. So CDC data on some hospital prescriptions of antibiotics. More than half of the antibiotics prescribed in the selected events in the hospitals they were following were not consistent with the recommended prescribing practices. So although they had very clear guidelines on how to prescribe, what to prescribe, etc., how to monitor, how to make sure they did follow-up, less than half of those actually followed that. And then they broke it out by conditions, and these conditions were interesting to me because they reflected much of what we track in shelters. Community-acquired pneumonia, so respiratory infections, antibiotic prescribing, so the practices they were using was not supported in 79% of patients. Urinary tract infections, antibiotic prescribing was not supported in 77% of urinary tract infections. So over-prescribing of antibiotics was occurring regularly. Anybody surprised by those numbers? No. You're like, oh, hell no. I could have told you that. And so I was talking about the CDC. We're going to switch over to the AVMA now. So as we enter the veterinary realm and thinking about this, the AVMA has outlined stewardship in veterinary medicine core principles that talk about maintaining animal health and welfare, and the welfare piece is important, implementing a variety of preventive and management strategies. So again, shelter medicine, we're ahead of the game in that, because honestly, a lot of our private practitioner colleagues do not necessarily think of that bigger picture management and support. And in some cases, they don't have to think as hard because their animals are not in captivity. They're sleeping on a pillow in somebody's bedroom, right? which has its own issues because that person sleeps on that pillow too. But there is this element of kind of thinking about the preventive and management pieces that comes, I think, more naturally to us. We want to use an evidence-based approach to making decisions to use antimicrobial drugs. And I'm smiling because I know at least a few of you are like, we don't have enough evidence to know if we have evidence-based recommendations, because I know there's some epidemiologists in this room and I see you. And so, we're trying to acquire evidence. And if anything, this talk is about needing to collect more evidence for the kinds of practices that we are prescribing to. Using antimicrobials judiciously and sparingly, and I think that's a piece that we can really kind of move the needle on. And then continual evaluation of outcomes of therapy, respecting the client's available resources. So the aspect that we need to follow the outcome, we need to know if they're responding to treatment, we need to make choices based on that, and client resources come into play. It's not just about what the textbook says. And so here's our kind of simple cheater diagram of the things that we want to think about from the AVMA's perspective, and then at the end I'm going to make us kind of apply this to the shelter perspective. So preventing common diseases, I would argue that is where we live in shelter thinking. Selecting and using antibiotics judiciously, evaluating antimicrobial use practices and making sure that that's how things are, that what we're doing is actually working. Educating and building expertise, so that's about getting the word out and making sure that our practitioners and our shelter leadership are actually thinking about these things, and then committing to stewardship and saying this is actually an important part of what we want to replicate in our organizations and in our communities. Here's a really wordy slide. And I thought about just trying to summarize it, and then I decided to leave it because I think the language is important and I wanted you to have it. So their principles of judicious use does mean that from the AVMA perspective, there is veterinary oversight of antibiotic use in animals. And that is in the context of a veterinary client-patient relationship. How many of you have heard that term before, the VCPR? Okay, so about half. And so the VCPR is something we talk about all the time in veterinary medicine, because essentially what it means is I have a relationship and knowledge of the client, the patient, and I am their veterinarian, and I am making choices based on that. In many states, it is actually written into regulation. And this has been a huge hot topic around telemedicine during the pandemic. Like, what defines that relationship? Can I do it over Zoom? How recently did I have to see them? All of these things, because a lot of the state regulations will say you must have a VCPR in order to prescribe a medication to an animal, period. In New York State, and I think I have this coming, but I'll say it now. In New York State, the VCPR is not in regulation. It's not a law, it is a practice guideline. Having said that, practice guidelines hold some weight. And so there's a constant kind of back and forth in terms of what a VCPR actually is and when we are allowed to prescribe antibiotics. Antimicrobials, according to the judicious use principles, should only be used after careful review and consideration of all of these points. We have a general or preliminary diagnosis that says we need antibiotics. Sounds easy. How easy is it? Not always so easy, depending on what the condition is. Culture and antimicrobial susceptibility testing when possible. Regimens for antimicrobial prevention, control, and treatment are established using accepted scientific and clinical principles. So have we actually put into play prevention principles in our organization? Antimicrobial therapy for uncomplicated viral infections should be avoided. There's one we debate around a lot. I'll come back to upper respiratory disease. Duration of therapy should be based on scientific and clinical evidence. Duration of therapy, I'll tell you that we still haven't decided what the correct, most optimum duration of therapy is for many of these agents and conditions. And then antimicrobial therapy should be targeted to ill or at-risk animals when possible. And other management strategies should be used to prevent infection in healthy animals. So, story time. One of the early shelters I walked into, which shall remain nameless, I quickly learned that the organization-wide approach for kittens under 8 weeks of age, healthy, sick, didn't matter, was that they all went on Clavamox. Why? Why? Prevent infection? Anybody heard of like using growth promoters in chickens or in swine? Like essentially, yes. Did it potentially help some of these kittens stay healthy or develop? Sure. Is it a good thing to do for a kitten of that age or as a protocol? No. Are we likely to be selecting for antibiotic-resistant organisms in very young animals? Absolutely. And so there's that moment when you look at an individual kitten that's struggling and say, antibiotics, no antibiotics. And that is an emotional sort of decision, and then that should be a clinical decision. But that individual may prompt a different decision than what should be a protocol across the board. Can we all agree on that? And so I had to like pry the Clavamox out of the hands of the fosters because it was what they knew and they felt like it gave them success, right? Are there other potential management strategies we might practice that could help instead? Absolutely. Like most of you, I'm sure in your organizations at various times, they were in Kitten Mountain. They had a foster that had 42 kittens, in our house. Like those sorts of things were happening. And so if you really want a yes/no answer, probably giving them all Clavamox was helping because the situation was such a challenge. Having said that, it's not a tenable or reasonable thing to do. It's certainly not practicing judicious use principles, and it's not enabling all that 5-way approach to the problem, right? Which is that systematic way that we in shelters want to be thinking about how we structure those plans and those protocols. So there's a lot of work at the federal level around this. And so the FDA, super interested in this problem. I put up the global death predictions, right, of 10 million deaths at the year 2050 from resistant antimicrobials. This is a global problem. The government has taken an interest. The FDA Center for Veterinary Medicine in 2018 put together goals for the fiscal years 2019 to 2023, and they started, not surprisingly, in production medicine. But what's important to recognize here is that in applying a risk-based approach to antimicrobial use, it was about two things. One is collecting data to kind of get an idea, what are we doing? Because we didn't know. Like, what are producers doing? We need to get an idea of how they're using antibiotics, what is the actual level of resistance at this point. And then the other piece is starting to collaborate to increase the stewardship process. And some of this is about making regulations, putting restrictions on what antibiotics are available, who can access them, how to use them. And so it's not just about, let's do a sort of information search, which is important, but realize that the regulations started coming down on what you could actually do. And so the FDA's role at a federal level, they can establish and regulate safety and effectiveness of animal drugs. So that is one of their big roles. And they can absolutely require that there's veterinary oversight on certain medications. So this is now a prescription-only medication. Their role in overseeing veterinary practice is really limited. So in terms of that VCPR, that is a state-level issue, not an FDA-level issue. And they do not have a regulatory role in animal husbandry or farming practices. So they can't kind of dictate those aspects. And so they realized they needed to enroll some other agencies and some other support. But do recognize that they absolutely are in the realm of being able to say, you no longer get that antibiotic. Because we've realized it's a risky one for, overusing it in animals has potential risk for people. We're actually going to take it away. And so they started actually taking antimicrobial resistance risk into consideration when they looked at what drugs are they going to approve for various uses in animals. Fluoroquinolones were removed from poultry, so bam, you can't use them anymore. And then they actually they prohibited the off-label use of cephalosporins in livestock, pulled some antibiotics in terms of feed and water, and actually have started a process to bring all over-the-counter antibiotics under prescriptions in food animal production. And most of us sitting here, I assume I don't have a large audience of production veterinarians or producers in the audience. No kitten farmers? No, just kidding. You are kitten farmers, we know that. But there's definitely this effort, like if you're not going to change your practices and you're not going to regulate yourself, then we're going to regulate you. And I think that level is important if we start to think about human impact. But there's also this aspect of trying to be proactive and think, okay, how do we think about this ourselves? What do we do in order to have some say in this matter? And again, we have very limited information on what's happening in companion animals. If that's one of the biggest takeaways I want to give today, is that we don't know a lot because there's not a lot of studies. I think I'm going to give you pretty much all the ones that are out there in the US. But the AVMA started doing some survey work in 2015. And 50% of antibiotics prescribed for pets not needed in some of the early survey work they did of hospitals and practices. Like if you actually tracked antibiotic usage and then outcomes or whether that condition was actually diagnosed, it did not look good. In a VTH hospital in a 2011 study, 38% of antibiotics prescribed for dogs over a 12-month period had no actual infection when the testing came back. So they would be prescribed antibiotics at the time of diagnosis, culture and sensitivity submitted, and then no actual infection present. And then they started looking at, well, what are vet students learning about antibiotics in veterinary teaching hospitals? And 90% of the vet students surveyed at a large veterinary training institution had not read the AVMA or FDA guidelines on AMS yet or judicious use. And so that training was not happening. And so this was kind of an alarm system, like, oh, we're not really teaching. We don't want them to become veterinarians where, if Baytril isn't enough, we'd like to know that they're actually getting trained in more judicious approaches. And certainly there's some elements where the pressures on companion animal veterinarians to prescribe antibiotics are not just about clinical signs in the animal. What else might dictate a veterinarian prescribing antibiotics to a pet or encourage a veterinarian to prescribe antibiotics to a pet? Yes, Dr. Wilcox.
The owner and older veterinarians.
Good. The owner may have a role in that. I know I have some veterinarians in the audience. I also have some owners in the audience, some technicians in the audience. Anybody ever seen a situation where the owner, maybe it was you don't have to say that, really wanted those antibiotics? Yeah, like probably all of us. And then older veterinarians. Yeah, absolutely. So if you came through vet school, here's another sidekick. If you came through vet school and you did not spend a lot of time in general practice settings, you spent a lot of time in a tertiary level teaching hospital, guess what kind of infections or cases present to tertiary teaching hospitals? Are they your basic ear infections, your basic wounds? No, they're the ones that show up with the superbugs, right? They're the ones that didn't heal out in the general practices. They're the ones that have multi-drug resistant bladder infections that are causing emphysema in the bladder wall. Like the monsters are the ones that show up at teaching hospitals. And guess what? Those are the ones the students see, especially if they're not spending enough time outside the walls. And so there's a bias as they come through. I remember, believe me, when I first went into practice, it was like a panic situation. Like, you've got the basic ear infection coming in and you're just like, but what if this is drug-resistant Pseudomonas? What if this is like that monster E. coli I saw in the Cocker Spaniel ear that had 12 years of ear infections, right? That showed up at my teaching hospital when I was a student. Like there's a fear. You want to make sure that your patient is getting the best in that moment. But the truth is we bias a lot of our students because they're seeing the worst of the worst rather than kind of the common in their training. And so the piece of trying to educate them more about common conditions are not superbugs, I think is an important piece of this and something that I think we're actually doing a better job on after this study. This paper was put out. That study was done a few years back. Here's a study that I put on here. It's a qualitative study. It was a survey study of British owners. And it was on kind of fear of antibiotic resistant organisms and antibiotic use in their pets. And so the common themes that came up as they talked about their pets, because a lot of the questions were like, would you want an antibiotic for yourself if you were sick? And they were like, no. Like, I understand the issues with antibiotic resistance. I understand that I can go back to my doctor. But if you ask them about their dog or their cat getting an antibiotic, they very much wanted their dog or cat to get an antibiotic. It was a different scenario. And so the common themes that came up as you read through these responses: fur babies, we share everything. I would want to err on the side of caution for my dog or my cat. They can't talk to me. They can't describe, what's happening. Whereas for myself, I feel like I could advocate for myself or go back to the vet. And so the conclusions were it's going to be really difficult to impact these close relationships. There was pressure on the vets from the owners, certainly for prescribing. And guess what? High risk opportunity for contact, because those animals slept on their pillows, licked their plates. I'm one of these awful people that I let them lick my plate and things like that. You're not meant to let them lick your plate, right? Like, that was one of the responses in the survey. And I laughed, and I knew it was true. Like, yes, we're not proud of it, but we kiss our animals, often on the mouth, right? We let them lick our faces. We let them sleep in our beds. And the second one was the one I pulled that was kind of like, yeah, it's completely different. Obviously, when it comes to me, I might not ask for the antibiotic or I wouldn't want it. But when it comes to your pet, you're going to be like, oh, yeah, absolutely, I want the antibiotic for my pet, because I don't want to take chances. So here's the moment when I say to you, the FDA is not ignoring that dog picture or that cat picture on the far right of that One Health slide I put up. That report they had very much had companion animal objectives in it. So yes, they were busy over here regulating food production and taking away, antibiotics for certain populations, which I'm in full support of, but they're watching us over here in the companion animal sphere too. And so this was their phase of actions, and they're kind of mid. I think the pandemic might have taken them on a little side trip for a bit, so I think they're behind. But their phase 1 actions between 2019 and 2021 was to kind of get public input on this and get an idea of what antimicrobial use practices in companion animals are and what their impact might be on the development of resistance, and then ensuring all dosage forms of medically important antimicrobials. And the definition of that is like antimicrobials that impact humans and animals, or may have particular uses that are particularly unique for use in companion animals that are under the oversight of a licensed vet. So phase 1 is like getting a sense of what's happening. And then phase 2, develop and implement a strategy for promoting antimicrobial stewardship in companion animals. And yes, that might be PSAs, public service announcements, guidance documents, recommendations, but it can be regulations that essentially restrict our ability to use certain drugs and when to prescribe them. And so it's important to recognize that although we're not at the forefront of what they're doing, we are absolutely on the radar. And it's again why I come back to the idea that we may need to think about regulating ourselves on some level. So the realm of prescribing antibiotics does belong to the veterinarian. That is written into not federal level, but veterinary practice acts, which are on a state level. And so it is fairly consistent that if you read veterinary practice acts across the United States, if there is one, there's a few states that seem to not have exactly the same level, diagnosis and treatment of a disease, prescribing medications, all fall under the scope of a licensed veterinarian. How many of you in shelters have a veterinarian standing there to prescribe antibiotics every single time antibiotics need to be prescribed? Yeah, we don't have that on a population level. And I'm going to support that. I don't think we need it on a population level as long as we have other things in play. And it's not just me supporting it, it's also, I'll show you some other things, including ASP. So, but it does speak to the fact that if we are going to be prescribing medications in our shelters, there should be some element of veterinary oversight. There should be some veterinarian who was involved in that conversation and can defend and authorize why that is occurring. Okay, and has a role in choosing what we're actually giving. How are we using these antibiotics? And so this is just a New York version, so I'll skip that for a minute. There is some recognition in the language also in terms of shelters, and we owe some of the language that we'll see in a couple of these documents to Dr. Lila Miller, who I'm sure most of you know. It was Dr. Lila Miller Day last week. who, along with Dr. Scarlett, who's in the back corner there, actually started the program, the shelter medicine program here at the college. And Dr. Lila Miller retired after over 40 years in shelter medicine. And so she played a role in some of the language that we'll see at the AVMA and the state level, that yes, we can absolutely use non-veterinarians and non-veterinary technicians to provide oral or topical medications and treatments to animals. But again, there needs to be a level of oversight. And that oversight, like everything, gets into specific definitions. So what does that mean? So direct supervision means a licensed veterinarian is standing on the premises and it basically assumes full responsibility for the procedure. And that is what we may or may not have in a shelter, depending. We probably don't have it every day, for sure, unless you have tied your veterinarian to a table and you are not letting them leave. Indirect supervision. Vets don't need to be on the premises, but they give written or oral instructions and is readily available and assumes responsibility. There's the sweet spot. Do we have somebody who is authorized and can defend that statement? And the AVMA Model Practice Act includes this statement specific to shelters. Trained employees may provide treatment for shelter-owned animals in compliance with written standard protocols developed in consultation with the veterinarian. So AVMA, not a regulatory body, right? It's our professional representation. Is this law? No. Can it be pulled out when somebody's being questioned and then essentially used as best practice? Absolutely. So it holds some weight. And that is the piece that I think we need to really be thinking about in terms of how we think about we're using antibiotics in our shelter. There should be a veterinarian engaged, and that veterinarian should be able to defend the practice and essentially have been able to authorize when and how and what is being used. There is also this element, I started with the VCPR earlier, but there's also this nice language in both the New York State practice guidelines in terms of the veterinary client-patient relationship and in the AVMA definition of the VCPR, that it's not just about, and I'm dropping down to the secondary bullet, it's not just about an exam of a single patient by a veterinarian. Another way to have that relationship is that there are timely visits by the veterinarian to the operation where the patient is managed. That was written for our large animal friends, dealing with farms, but we're cat farms and dog farms. And so it helps us. So, it's allies in unexpected places sometimes. And then medically appropriate and timely visits by the patient to the veterinary facility. So if you're taking animals out to a vet, but they have an ongoing sense of what's happening in your shelter, or if they have timely visits to your shelter, and know the organization, it puts them in a position to be able to give this sort of oversight and establish that relationship. It does mean a veterinarian is readily available for follow-up. So I do quite a few shelter consultations, and I will tell you, I will walk into shelters where the antibiotics are being ordered under the name of a veterinarian that hasn't been there in 5 years. That's a problem. That's not timely. I don't really know what timely is. I object to language like that, like timely, adequate, appropriate. Like, what does that mean? But I'm pretty sure 5 years is not timely. So, that's on the veterinarian and that's on the shelter. I understand why it happens, and I'm sympathetic to why it happens because it's really hard to get a veterinarian sometimes, super hard. And so, if you lose your vet and they don't forget to take the name off, but it is a problem because that doesn't truly fit stewardship for sure. And may impact your actual judicious use. Okay. In patient records, if antimicrobials are being given to a patient, it needs to be in a record. I think that's pretty obvious, but I'll say it out loud anyway. ASV has looked at this, particularly thinking about the new guidelines and looking at kind of what veterinary supervision is. And it's just another emphasis that, again, this is not a regulatory body. They are not writing laws. They are essentially making professional recommendations. But the idea that if you have health protocols and they are written and they have been developed in consultation with a veterinarian, then they can be implemented by trained shelter staff. And do notice that doesn't say licensed vet tech. That says trained shelter staff. And so trying to really broaden what shelters are able to do under veterinary supervision by essentially broadening what that looks like for us as production doctors, similar to farms. Back to the cat farm. All right, so how are we doing? So I told you we don't know much about how we're doing in companion animal practice because we're not really studying it. But there's a couple studies out there. So this is a recent one that looked at 3 veterinary teaching hospitals over a 6-year period to see what antibiotics are being prescribed and in how many sorts of appointments. And so good news, first generation cephalosporins were 1/3 of the prescriptions and occurred in just over 10% of visits. So that's a first-line antibiotic. It's an excellent choice. It's a safe choice. It's a judicious choice if you don't exactly know what you're dealing in. And so I love the fact that that was at the top of the list. Cephalosporin 3rd generation, that kind of ups the ante a little bit in what you're using. And then if you get into your fluoroquinolones, those are kind of the ones that you really want to see used much less often. And that was true in this study. So this is one of the first studies looking at multi-institutions and what's actually being done out there. And it seems to have some pretty good indicators that we are sort of paying attention to what should be happening. This is one that is still in, I don't think it's actually gone to publication yet, but this was across, done at Minnesota and was looking at small animal and equine practices and kind of trying to capture what the incidence of antibiotic prescription was in appointments. 25% of appointments were getting antibiotic prescriptions out of all the appointments. And 3rd generation cephalosporins were the most prescribed. So important to recognize there that that was an up the ante in terms of what kind of antibiotics are being used. And I suspect one of the things here is just to kind of pull these out a bit. First generation cephalosporins, super cheap, broad spectrum, administered a couple times a day, and often your first choice. However, there are 3rd generation cephalosporins, which are once a day or injectable, and therefore easier to administer. And so it comes down to like, that's the balance, right? There may be instances where you reach for that 3rd generation injectable because of compliance or because of concerns for getting the animal back. And that's certainly true in a shelter or a spay-neuter setting. But those are the sorts of balances that we're looking at. Ideally, that 1st generation cephalosporin would be the first choice. But again, it's got to be administered twice a day, orally. And generally, you're looking at least a 5 to 7 day course for most indications. And so compliance can become an issue. Let's talk about these. Do know that there are consensus statements out there on antimicrobial use. These are consensus statements, and I put that in quotes because there's not absolute consensus on these statements. There seems to always be an outlier in most questions. But for the common conditions, and they're the big ones we talk about in shelter medicine, for respiratory disease, skin infections, and urinary tract infections, there are consensus documents out there that clearly outline what the best practices are in terms of diagnostics and then therapeutic use. And most of the people on these panels are internists. And so yes, there's a kind of specialty angle, but truthfully, they are extraordinarily applicable to shelter protocols and settings. This is my go-to for creating a protocol and looking at how it fits in a shelter setting on a population basis. And so they do exist. And they've existed for a while. The urinary tract one was revised in 2019, but originally existed from 2011. And in the revision, they actually shortened the duration. So humans, I don't know if I said this yet or not, you get a urinary tract infection, you go to your doctor, you're probably getting 3 to 5 days of antibiotics at this point. Short duration, slightly higher dosages, very effective, less likely to result in resistant organisms. That move really hasn't made it to veterinary practice, but it is a recommendation in those 2019 guidelines that we're looking at 3 to 5 day courses. That's what's currently recommended, not commonly practiced. And so this paper really interested me. This was a retrospective paper done in a teaching hospital rhyming with Cornell. And a resident pulled records for a calendar year and looked at what antibiotics were being prescribed by ECC and critical care services. And then it's not even kind of talked about in the abstract, although there's one line. And then what she did is she looked at all the aspects of the appointments in terms of what were the clinical signs, the presentation, diagnostic tests that were done, and she compared them to what the common guidelines or recommendations are, AKA, I think most of it came from this. And so she kind of defined these criteria as to what would be most appropriate based on those guidelines, and then compared the practices or the prescriptions to the guidelines. And the final sentence in the abstract is, adherence to published guidelines for urinary and respiratory infections was poor. And so even though kind of the numbers of antibiotic prescriptions were kind of in line with what we see, and how antibiotics, they were really using kind of first line amoxicillin, ampicillin, metronidazole, those are all first line antibiotics. Even though they were using the antibiotics in terms of first line and only 16% of them were getting antibiotics, there was this element of, are they following the guidelines that exist? Now, I want to call out and say that the guidelines often ask for like a culture and sensitivity in every sort of case that might be an infection. The guidelines look for particular duration or antibiotics in particular areas. Doxycycline is one that the guidelines recommend highly for upper respiratory infection, and that's what we recommend as a first-line antibiotic. Some of the teaching institutions really struggle with doxycycline in terms of forms that they can get, depending on compounding laws in your state and all of these issues. And so there are other aspects. So I want to give a shout out that just because they didn't check all the boxes doesn't mean, because honestly, we don't check all the boxes in some cases. We're not doing cultures and sensitivities on simple, uncomplicated presentations of cases necessarily. So it's not as bad as that line makes it seem, but it was interesting to me. And I thought pretty brave of her to kind of call out the institution that shall remain unnamed. Do know that as I'm advocating for us to think about this and kind of be proactive in regulating ourselves, we're seeing the same sort of thing in our teaching institutions. So Ohio State has really taken the lead in a lot of this. They have a very proactive group looking at antimicrobial use guidelines within their hospitals and then kind of broadly. And they have a lot of work happening in this arena. And I'll talk a little bit about that in terms of the collaboration that we have. There are all kinds of charts that have come out. This Are You Protecting Your Antibacterials is a really nice chart. That is Veterinary, and it was put out by the British Small Animal Veterinary Association, and is a really nice tool to kind of help you think about the indications for antibiotics and which ones you would use. These are, you can download them and print them out, like they're free and available. And then individual veterinary hospitals, I was at Tufts at Tech, which is their low-cost subsidized care clinic in Worcester, and they have developed, it wasn't just them, it was actually done for their teaching hospital, and then they use it in that clinic, but they have been very proactive in looking at making sure students have kind of this readily available poster. This poster lives next to the pharmacy in the low-cost hospital. It has the indications, the dosing instructions, like what the best practice recommendations are for different conditions, and the students reference that as they stand in front of the pharmacy and choose their drugs. And so really trying to make veterinarians and new veterinarians conscientious about this process and how it's not just about picking something out of the book. The last thing I want to touch on, which I've just started going into, is like this cost and access piece is really important. We in shelter medicine are actively engaged in communities where accessing healthcare for people is super challenged, and accessing healthcare for their animals may be impossible. And so the CDC Social Vulnerability Index is a tool that has been used for disaster planning and essentially identifies communities that in the event of a disaster would be particularly challenged in being able to respond to that disaster. And I think this has application in so many ways, because we can use this in a lot of ways to try to kind of project that onto what the case may be for animals as well, recognizing that families, for most of our pet owning population, the family unit includes the pet, right? And we saw some good examples of that. I don't have to convince this audience, I'm pretty sure. So this is a tool thinking about vulnerability in particular communities in terms of healthcare for themselves and their animals. And this is a recent project, I just wanted you to know it's out there, that essentially took that information along with a bunch of other metrics and created a map in terms of veterinary care accessibility. And so this is available online, and you can actually kind of look up your area, look up your zip code, recognizing that all of this data is conglomerate data. It's messy, but I still think it's an interesting overlay in thinking about the fact that we have populations where, I mean, a drug-resistant antimicrobial agent is a huge problem everywhere, but geographically in this country, we also have limited equity in terms of people's ability to seek treatment, and then also being able to prevent infections essentially in our family units. I'm going to skip some of that to say that in shelter medicine, we live in the world of protocoled medicine, and I think we've gotten pretty comfortable with that. Veterinarians write protocols, people follow the protocols. That's how we actually treat populations of animals with limited numbers of veterinarians. And we use our paraprofessionals, our technicians, our trained medical staff, our owners to help us do that. I think we need to see more of this, and it's growing in the human medicine field. So we already see this sort of protocoled care and urgent care for human medicine. First responders, if you train as a wilderness first responder, you're essentially given 7 protocols that if you have no medical training, you are able to enact as long as you can defend that you were in the wilderness and had limited access to help people. And so there's this aspect of figuring out context-dependent protocols where people can enact our medical treatment plans without the veterinarian having to put their hand on every single animal. And we already have this in corporate practices. We have some of this. Production medicine depends on that, and so does shelter medicine. And I think it's worthwhile thinking about how we can apply this in a broader sense in communities, and that connects back to antimicrobial stewardship, making sure that the treatments that we're prescribing, the antibiotics we're reaching for, the things that we are doing are the best and most judicious use of the tools that we have. There have been some interesting studies in human urgent care around how practitioners feel about protocoled medicine. And there's some mixed reviews. Some of the paraprofessionals aren't super excited about it because they feel like it tells them what to do and reduces their thinking. But in the vast majority of cases, people see it as a benefit. It helps with cost containment because the protocol generally accesses first-line treatments first and doesn't jump to when Baytril isn't enough, doesn't jump to your fluoroquinolines or your higher levels. Using protocols improved patient outcomes, prevented errors, made the job easier, and gave paraprofessionals more autonomy. And so I think there's lots of opportunities to look at how we can employ this in community medicine settings and shelter medicine settings to not only better impact the health of those individuals and those populations, but also this broader sense of the environment and how we play a role in antimicrobial use and stewardship. And so shelters have, I think, a relatively clear pathway into this in terms of preventing disease, controlling conditions, employing these guidelines, and doing this work. And I hope potentially that there's something new that you picked up today that can help guide what's happening in your practices. And no, I didn't get through all my slides, but we'll just wrap it there. So thank you very much.